as Dr. Paris is setting up her talk on corneal patches and matches, any questions for Dr. Radhika? Will you please take the dais with me, ma'am? Yeah. You have to go? Okay. Okay. I think, yeah, sure. Thank you. Over to you, Paris.
Yeah. Good afternoon, everyone. Thank you, Dr. Panati. It's like talking on corneal matches and patches in 6 minutes is a little difficult, but I've tried to bring in clinical cases more here. And little financial disclosures. We all know that the surgical management of corneal thinning or melting disorders is required when all else has failed, and either there is a corneal melt or an impending perforation. The principle of surgical management would be halting the disease process medically or systemically by treating inflammatory or infectious causes and surgically restoring the corneal integrity and anatomy by tectonic reconstruction of the cornea. Other adjunctive procedures can be added to that, like using tissue adhesives, amniotic membrane, or conjunctival resection, etc., etc. This just explains, like, if we are dealing with smaller peripheral melt or a perforation, probably a tissue adhesive bandage contact lens or a Tennant's patch graft or a lamellar graft can be used for those. If it is a little larger than that, with an iris prolapse, probably sometimes you can use lamellar graft, or at times, depending on how much involvement is there, a Tennant's patch graft or a full thickness patch graft. If it is peripheral thinning with ectasia, like PMCD or Chirian's marginal degeneration, one would resort to lamellar or full thickness, or at times, sometimes some patients would require a mushroom graft or an onlay or a tectonic large diameter banana or a C-shaped graft. This is just a clinical case where I'm just demonstrating a surgical technique of using a Tennant's patch graft. This patient probably had an RA, and as you can see here, there is a previous full thickness patch graft done elsewhere, and again he has developed a corneal melt and iris prolapse. So we didn't want to really put in another patch graft because it was small, and you can just go ahead and use Tennant's tissue from the same eye. Because it was very inflamed eye, there's a lot of, heme along with. After stuffing the Tennant's tissue into the perforation, like after repositing the iris, you can take an infinity sutures with 10 nylon to make sure that the Tennant's tissue is well secured into the wound, as you can see here. And the chamber was filled with bubble. And you can close it with a bandage contact lens. So these are the post-operative picture of the same patient. And this patient, if the perforation is larger than 2 to 3 millimeter, can be used for it can be, the Tennant's graft can be used for up to 3 to 6 millimeter size of perforations. Because this is an autologous tissue, there are no risk of any immune reactions. It is available in abundance, and there is no dependency on donor tissue availability. This is almost doable by any clinician into the clinic. This was another case where there was a known case of rheumatoid arthritis diagnosed almost 1.5 years back, had undergone tissue adhesive and bandage contact lens procedure elsewhere a few times for maybe possibly a peripheral ulcerative keratitis, was initiated on DMARDs, disease-modifying anti-rheumatoid drugs. After systemic workup, on next follow-up, she presented like this because she was earlier non-compliant and she had discontinued the management. So because there was underlying tissue thinning, we ended up doing reposition of the iris, and a lamellar patch corneal graft with peritomy was performed to cover the peripheral corneal thinning and restore the tectonicity of the globe as the perforation was smaller. However, the underlying cornea was very thin. So these are the patients who would require systemic management along with ocular management, and that is the key. So a co-management with an immunologist is very crucial for such cases. Only ocular management may not really do well for such cases. This is another example of a similar thing. This patient presented with sudden onset of watering pain and redness and photophobia, a known case of a patient with KCS and rheumatoid arthritis on systemic management, but was lost for follow-up sometime, and presented like this because there was the bed was very unhealthy. Probably we decided to do a patch corneal graft rather than a Tennant's patch graft here, and about a small 5.5 millimeter full thickness patch graft was performed to salvage the eye. These are the post-op pictures of the same patient. This is another example of post-pterygium surgery melt who presented like this. Since the area was larger with the iris prolapse, here also we used about 5.5 millimeter full thickness patch graft after taking care of the inflammatory area into the surrounding tissue. This is a similar example wherein we have used an elliptical full thickness patch corneal graft with peritomy, and iris abscission was performed after systemic workup and management. I have, one interesting case to share. A 52-year-old gentleman who was followed up for past 2 decades presented with watering, dimness of vision in his left eye for a few months. There was a supranasal corneal thinning with superficial vascularization and lipid deposition. So as you can see here, involving almost 5 clock hours of peripheral cornea with extreme ectasia and visual acuity of counting finger 1 meter. So Aterian's marginal degeneration was diagnosed, and what we did here is, it was very thin, almost Desmet's thin. So we didn't want to kind of, wait till the perforation occurs, and we went ahead and did a customized kind of corneoscleral graft here for this. The grooves were made at both the anterior and the posterior aspect of the thinning. And as we didn't have much, the refined size which was adequate enough to take care of that circular area, we ended up using the surgical drape as a stencil for this patient. And a similar tissue was excised from the donor cornea. It was kind of, impaled carefully, and the size was trimmed. And the graft was sutured into the peripheral gutters which were created. This was almost like an onlay graft. And these are the post-op pictures after 8 weeks of surgery. And this is after almost 2 years. The globe integrity was well maintained. The corneoscleral graft is well opposed with the ocular surface. The best corrected visual acuity improved to 6.9 from counting finger 1 meter. So you can resort to either a full thickness patch graft or a lamellar patch graft depending on what kind of condition you are dealing with. Here we couldn't salvage this particular eye with a lamellar surgery. So in this case, we ended up doing a full thickness banana or D-shaped graft to salvage the eye. So the same patient subsequently can be taken for a central penetrating keratoplasty based on the control of the disease process. So the take-home points here would be each clinical situation needs proper assessment and planning of the surgical approach. One has to control the progressive pathologies first. The conditions with systemic disease will necessitate long-term systemic management along with ocular intervention to salvage the eye. And some complex situations may need combination of techniques to maintain the tectonicity and functionality of the eye. Thank you very much.
Thank you, Dr. Paris, and we'll now invite our next speaker, Dr. Uma Sridhar, to talk to us on her topics. Amniotic membrane grafting here. Any questions for Dr. Paris? Yes.
Ma'am, I want to like to know that what is an average time of Tennant's patch graft to well take up? Like when can we remove the suture and expect the perforation to be completely healed?
Like you can wait for some time, like a couple of months, for the tenon to get integrated into the cornea. And people have done even a post-Tenon's graft, a phacoemulsification also. So it integrates well to the cornea. But it does require a little longer time. Like sutures, maybe, when you see that the sutures have gone looser, you can remove that. But it takes a little longer time for tenons to get integrated into the cornea, a couple of weeks to months.
One comment, and when I see these eyes with severe systemic diseases, rheumatoid arthritis and all, and especially if there is PUK and they're nearing perforation is imminent or has occurred, these eyes are very highly inflamed. You can't wait for rheumatologists to start anything. And we just go start systemic steroids by ourselves, 60 milligrams or so, while waiting for rheumatologists to intervene. What I'm trying to say is that this is really a hot eye and it needs to be taken care of with anti-inflammatory agents.
Yes. Yeah, most of the cases we didn't wait for total systemic workup, but like they were put on IV methylprednisolone, probably systemic oral steroids may not work instantly for these cases. So they have to be pulsed first after ruling out the other systemic condition, physical examination, and then they were taken for a surgical intervention, and later on they were initiated onto systemic management.
And I think the PUKs are the ones which are, especially the elderly PUKs, they do have compounding morbidities on perocular surfaces here. So even when you give them acute immunosuppression with pulse steroids, they do tend to be quiescent for a period of say 3 to 6 months, and you will invariably see them come back with a melt starting on here. So these are pretty much difficult scenarios. Some of these surfaces are very, very difficult to manage here.